Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator. It's my pleasure to serve as the host of the seminar series. I'd also like to introduce Jenny Rank, our CGNE Program Specialist, and thank her for all of her assistance with implementing our seminars. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care, Pennsylvania. Today's seminar, Clinical Factors Associated with the Quality of Interactions Between Staff and Hospitalized Patients with Dementia, will be presented by Dr. Anju Paudel, Assistant Professor at Neese College of Nursing and member of our CGNE leadership team. Before we begin the presentation, we do have some disclosures and announcements. First, it's important for you to be aware that the November 30th seminar on Aging Inequalities by Dr. Kelly White has been canceled, but it will be rescheduled as part of our spring 2024 series. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continual professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and we did not need to identify, mitigate, or disclose relevant financial relationships. Please be aware that Zoom in and out times are recorded as part of our attendance for the requirements for contact hours, and a post-event evaluation survey must be completed by RNs seeking contact hours. But we do encourage everyone to complete that evaluation to provide feedback on the seminars. And the link to that evaluation will be provided at the end of the seminar in the chat. We'll also send you an email within 24 hours. And those evaluations need to be completed within a week. Certificates are emailed to qualified RNs within a month of the seminar. Just as a reminder, this seminar is being recorded. And when we get to the Q&A discussion portion of the seminar, you are welcome to put your comments or questions into the chat. Jenny will help me monitor that. And if you prefer to share your comment or your question aloud, please use the raise hand feature at the bottom of the screen, and Jenny will unmute you so you can share your comment or question aloud. And if you have any questions or concerns, you're always welcome to reach out to us at cgne@psu.edu. Next, I'd like to introduce Nahida Akhtar, one of our CGNE PhD student affiliates. Nahida presented a poster at the 2023 GSA conference last week entitled Tools for Measuring Person-Centered Care for Older Adults in Long-Term Services, a Scoping Review. Congratulations on presenting your poster last week at that large scientific conference, Nahida. And thank you for being so engaged with our center and for introducing our speaker today.
Thank you so much, Janice, for your nice introduction. So I'm so excited to introduce Dr. Paudel. So Dr. Paudel is an assistant professor at the Penn State Ross and Carol Neese College of Nursing, and she has been a full-time faculty member since 2021. She's also a part of the CGNE leadership team. So Dr. Paudel is originally from Nepal, where she completed her undergraduate nursing education and obtained her BSN Following her interest in gerontology and geriatrics, Dr. Paudel came to the US and completed graduate studies in gerontology from Miami University in Ohio in 2015. While at Miami, she worked as a project manager and as a lead research evaluator for intervention research studies focused on well-being of persons with dementia in long-term care. The exposure and experience in research continued post-graduation as she worked as a, worked as a project manager for a federally funded research project focused on testing and standardizing functional assessment measures for home and community-based service. This experience altogether inspired Dr. Paudel to pursue PhD, and she completed the nursing PhD program from University of Maryland School of Nursing in 2021. Dr. Paudel's research focused on understanding staff-residents interaction in dementia care factors that influence these interactions and finding ways to support staff in building meaningful relationships and interactions with the residents with dementia. Her recent pilot work focused on optimizing self-resident interactions in assisted living was funded by the Council for Advancement of Nursing Science and Southern Nursing Research Society dissertation grant. So please welcome to Dr. Paudel.
Thank you, Naida, for that wonderful introduction. And good afternoon, everyone. I appreciate you all being here attending this presentation. I'll now go ahead and share my screen. Are we all able to see my screen? Just a thumbs up?
Yes.
Thank you, Jenny. So this presentation is titled Clinical Factors Associated with the Quality of Interactions Between Staff and Hospitalized Older Patients with Dementia. This has been informed by some of my prior work in long-term care settings where I really examined the quality of care interactions in those settings and also different factors influencing interactions in those settings. So it's not a new knowledge. All of us know millions of individuals, especially older adults, are affected by Alzheimer's disease or dementia, and current estimates suggest about 6.7 million older adults age 65 and older have dementia. And those with dementia often have more frequent hospitalization than those without dementia, where hospitalization is associated with many factors, especially adverse events such as falls. And these are really contributed by multiple factors or a combination of factors, physical and cognitive decline, the existing comorbidities, and also use of multiple medications, especially antipsychotics. So, and during hospitalization, the experience of the persons with dementia is significantly shaped by their daily interactions with care staff, and the quality of care also greatly depends on the quality of interactions. When we're talking about hospitalization among patients with dementia, it's important to understand that hospitalization is often difficult and confusing for this population, especially because of the unfamiliar environment and most importantly, due to communication challenges. Language impairment pose communication challenges with care staff in the hospital settings, resulting in poor relations and interactions, and a lack of meaningful and relational interaction, including undesirable or negative encounters in dementia care, is associated with patients with dementia not receiving the same level of attention in services related to mobility, hygiene, and comfort, and such than those without dementia. And such discrepancies in care can make the persons with dementia feel that they and their choices are not regarded well or are disregarded. Now let's switch gears to factors associated with interaction. So there's some prior evidence on factors associated with the quality of interactions, where prior studies have looked at what factors really influence the quality of interactions between staff and persons with dementia. And those prior work suggests that clinical factors such as level of cognition, mood, delirium, severity, functional ability, physical symptoms such as pain, and the pharmacological and non-pharmacological interventions can influence interactions. Likewise, non-clinical factors, especially the sociodemographic characteristics such as age, gender, race, marital status, and educational status can also influence the quality of interactions. So in summary, we can say that hospitalization is challenging and difficult for persons with dementia, and there are a multitude of factors that can influence their quality of interactions with staff, and prior work has provided some evidence on the potential factors. However, a lot of those work was focused on residential and long-term care settings. And as we all know, hospital settings are a little bit different than residential care or long-term care settings, in that the hospital settings have fast-paced environment, and also the focus is really on managing the clinical symptoms. The priority is on management of acute clinical symptoms. Also, the nature of interaction between the care staff and hospitalized persons with dementia is different than in long-term or residential care setting, as the persons with dementia don't have that long-standing relationship with the staff, as we can see in long-term care settings. So based on this foundational information, the purpose of this study was to really examine the clinical factors that are associated with the quality of interactions between care staff and hospitalized patients with dementia. And as I mentioned before, we had done some of this work in long-term care setting, and we were really interested in seeing what findings we get when we conduct similar study in hospital settings. So based on the prior evidence, we hypothesized that clinical factors, including level of cognition, depressive symptoms, functional status, pain, delirium, and non-pharmacological intervention use would be associated with the quality of interactions among hospitalized older patients with dementia while controlling for the covariates. So this is a secondary analysis where we looked at one of the important outcomes in intervention study focused on optimizing function among hospitalized patients with dementia. So we used data from the final cohort of that study, which was a randomized control trial implementing FFC, or family-centered function-focused care. This study was funded by NIH, and the principal investigator is Dr. Murray Bolts from Penn State Nice College of Nursing. Our sample included 140 hospitalized older patients with dementia. For data analysis, we utilized the SPSS 28 version 28, which is just a data analysis software we use. We started with exploring the descriptives of the participants. So we looked at mean age and other frequencies and percentages of other variables. And following that, we conducted bivariate analysis, where each association of each of those factors was looked upon independently with the quality of interaction. And then following that, we conducted multiple linear regression for hypothesis testing. And for all analysis, we considered P less than 0.05 for statistical significance. In this slide, you can see the measures utilized in this study. The outcome measure or the dependent variable was really the quality of staff-patient interaction. And it was measured using a tool called QUIS, or Quality of Interaction Schedule, which really allows you to observe the ongoing interaction between staff and person with dementia. And then based on that observation, you code it in 5 different categories, including positive social, positive care, neutral, negative protective, and negative restrictive interactions. So you code as 0 present, 0 absent, and or 1 present. And based on that, you can also create a summary score. And the summary score range from 0 to 7, where higher score indicate better or more positive quality of interaction. The predictors in this study included the clinical factors, such as the level of cognition, which was measured using Montreal Cognitive Assessment, or MoCA. Patient's mood, measured using Cornell Scale for Depression in Dementia. Delirium severity, which was measured using Confusion Assessment Method, the SWORD form of that tool. Functional ability of the patients was measured using Barthel Index. Physical symptoms such as pain was measured using Pain in Alzheimer's Disease, or PAIN-ID. And then the non-pharmacological intervention use was assessed using a checklist, which was prepared by this study PI, and it listed all different possible non-pharmacological interventions that can be used in hospital settings, and it's coded as whether used or not used, so it's binary 0 or 1. The covariates included age, gender, race, marital and education status, and length of stay of the patients at the hospital setting. So in this slide, you can see the descriptive characteristics of the sample. And as you can see in the table, on average, our sample, or the hospitalized patients with dementia in our sample, were about 82 years old. They had moderate cognitive impairment based on MoCA. On average, they had about 6 comorbidities, and they stayed at the hospital for about 7 days. They also had moderate functional impairment. About 3 non-pharmacological interventions were used during this stay. The patients were observed to have none to mild pain. Likewise, there was low level of depressive symptoms reported in this sample, and also low levels of delirium severity in this sample. The quality of staff-patient interactions, though, seemed higher or better based on the score of 5.8 out of 7. Our sample was primarily female, white, not Hispanic or Latino population. Majority had more than high school education, and half reported as being married. So this really gives a snapshot of what the persons with dementia look like in our sample in terms of the sociodemographics. So this slide here really gives you an idea, or gives a snapshot of the major findings of this study. I would like to draw your attention to the text in bold here: non-pharmacological interventions and PAIN-ID. And as you can see, the p-value is less than 0.05, suggesting that these two were found to be associated with the quality of staff-patient interactions in hospital setting. So to summarize what we just saw in the prior slide of the table with the major findings, accounting for 17.8% of the explainable variance in the model, the non-pharmacological intervention use and presence of pain were significantly associated with the quality of staff-patient interactions. Non-pharmacological intervention use was positively associated with the interaction, where for every non-pharmacological intervention use, there was about 0.2 point increase in the quality of interaction. Pain was negatively associated with the quality of staff-patient interaction, where a 1 point increase in pain was associated with about 0.2 point decrease in the quality of staff-patient interactions. So what do these findings mean now that we examine the factors associated with interactions, and we saw there were two factors that really, clinical factors that really influence the quality of interaction. What do those findings really mean? So first, I will start with pain. So we saw pain had negative influence on the staff-patient interactions. Pain, as we know, especially chronic pain, is one of the common clinical symptoms among patients with dementia because of the gradual cognitive decline and also the resulting impairment in communication among patients with dementia. It may impair their ability to verbalize or express pain. And as a result, we may see pain being expressed as undesirable behaviors, which we technically term as behavioral symptoms of distress, such as agitation, aggression, or resistance to care. So as a staff member caring for patient with dementia, it may be helpful to really take those undesirable behaviors and try and see the underlying, if there is an underlying pain resulting in those behaviors, because when there are, the behavioral symptoms of dementia are really distressing to staff, and it can really negatively impact the quality of interactions between staff and the patient with dementia. So it's really important to try and explore if there is underlying pain in the patient with dementia, and use appropriate pharmacological and non-pharmacological measure to manage pain among the patients with dementia. The non-pharmacological intervention use was found to be positively influencing staff-patient interaction in this study. So what does this tell us is that it's beneficial to use non-pharmacological intervention. And we all know there is long-standing evidence that use of non-pharmacological interventions, such as art therapy or music therapy, aromatherapy, it can really help to manage behavioral symptoms of distress, especially help with enhancing the mood of the patient. So utilizing these non-pharmacological interventions can provide opportunities for more engagement in more positive care interactions, because when the patients are in a better mood, it might help with that engagement. And also, if you think about it, just the process itself of engaging in the non-pharmacological intervention, like for example, say music therapy. In music therapy, if you are really working with the patient in creating a playlist, that itself that interaction opportunity itself is more, might be more smooth and then easier when it comes to engaging in interactions. Art therapy, another great example. I don't know how many of you know about opening minds through arts. It's a type of art therapy for persons with dementia where a volunteer is paired with the person with dementia, and together they create a beautiful art project where majority of the work is done by the person with dementia, and the volunteer is just there to as a helping hand to assist. And just during that process, it gives many opportunity, a really good opportunity to engage in that positive interaction. So it's really helpful when it comes to having that interpersonal relationship and promoting meaningful interactions with the patients. Therefore, it will be helpful for staff to consider utilizing non-pharmacological intervention to optimize care interaction and also to manage some of the clinical symptoms such as pain itself. So those were the main key takeaways for this work, but also definitely there is more work that needs to be done. So future studies or future work can focus on exploring ways to promote non-pharmacological intervention use to manage clinical symptoms like pain, and also to promote patient comfort in acute dementia care. Now that we know that it's really helpful when it comes to optimizing care interactions, we need to explore ways to promote use of these non-pharmacological intervention. Also, this is one of the preliminary work. There is limited work done in this area, in this topic, especially factors related to interactions in hospital settings, especially when it comes to caring for persons with dementia. Therefore, we need to continue to investigate the clinical and non-clinical factors that can contribute to the quality of interactions in acute dementia care. And also, as we continue to investigate the factors, it's also important to consider other factors that we did not consider in this study, such as staff's level of knowledge, training, experience in caring for persons with dementia, and also the level of acuity of the patients and other environmental factors within the hospital settings as well. This was a secondary analysis, so some of that information was not available, but that can be also looked at when we continue to explore on this topic in the future. So of course, there are always strengths and limitations of work, and major strength of this work is that we identified some important clinical factors that are related to the quality of staff-patient interaction in hospitalized dementia population. And as I mentioned earlier, there has been limited work in this population. So that's one of the major strengths of our study. And because this is secondary analysis, and there are some limitations, findings from this study perhaps can be interpreted with caution, as the sample in this study really included patients from 2 medical units of a hospital of one state, with the sample being mostly white and non-Hispanic or Latino population, which really limits the generalizability of our findings. And also, this is a cross-sectional study, meaning we just looked at the data from one point in time. So we can't really establish causality, where meaning we really can't say like the factors that we found to be associated with interactions are really the antecedents of the quality of interactions. It does tell us that they have some association with interactions, but we cannot confidently say to the fact that these are really the antecedents. So future work can look at more longitudinal data to establish that causality instead of data from one point in time. And as we know, with collecting data with observational measures and self-report measures, where you're interviewing people or at the place observing, there are always some bias related to social desirability or memory issues. For example, during the observation of the interaction, staff might have interacted in a desirable manner with the patient with dementia, and also while reporting answering some of the questions or reporting some data, there might have been affected. It might have been affected by memory issues. Although in this study, to really address the social biases related to social desirability, staff were informed that the observations were being done to really understand how day-to-day interaction looks like in hospital settings, to help the researchers understand those interactions. So those were some of the limitations. I believe we finished a little bit early, but that means more time for questions. So thank you for being here, attending this presentation, and I will be happy to take any questions.
Well, thank you so much, Anju, for that wonderful presentation. As I mentioned to you before we opened up the seminar, I was at GSA last week, but didn't have an opportunity to listen to your presentation. So I'm super excited that I was able to hear it today. So we are already getting some questions and comments in the chat. So, just an invitation to others in our audience that if you'd like to provide a comment or ask a question of Dr. Paudel, you can either enter it into the chat, or you can raise your hand by hovering over the little raise hand symbol at the bottom and clicking on that. And then Jenny will unmute you and you can share aloud. So Khalid has written, what are the non-pharmacological interventions that were considered in this study? I know you mentioned that there was a checklist, but can you describe, some of the items that were on that checklist?
Yeah, so as I mentioned, they were mostly a checklist of possible non-pharmacological interventions, and they included things such as listening to music, walking in the room or hallway, validation, audio videotapes, warm blanket, hand-foot massage, or any form of reminiscence or diversional activity. These are just some examples. And I think some of the others were also related to revolved around socialization with peers during meal times. So those were some of the examples that were in the checklist.
As a follow-up to that question, I'd like to ask, did you find on the medical units, these were medical units, 2 different medical units, right? Were they a general medical unit, or were they specialized in any way? Did they have any specialized training in dementia care?
So I believe these were general medical units, and I think the staff had the standard training as they would have in the general unit.
And then you described all of these, great ideas for non-pharmacological approaches. Did you find the staff had the resources available to implement things like that? Did they have iPads or, headphones for music, anything like that?
So I believe it was I think most valuable resource, time. Because you need to invest time, and with all the turnover and how busy these settings are, I think time was one of the concern. With regards to other resources, I would say perhaps it was not at the level desired, and it's based on my experience in other hospital settings. I really didn't go to these particular settings, but that's what I have seen in other settings, other hospital settings.
Yeah, I think that's a really important point, that time is probably one of the most valuable resources that and adequate staffing levels that allow them to have the time to implement non-pharm approaches. So Dr. Donna Fick wrote excellent topic and presentation. What are your next steps in terms of this research?
So I think in this study, we really just looked at non-pharmacological interventions as one of the factors that may be associated. As a next step, I think it would be interesting to really look at this one variable in depth and really try to understand which maybe perhaps group them in categories like psychosocial interventions or sensory interventions, and really try to understand which are most effective when it comes to interaction. So yeah, it's given that it's a really promising finding that it's good to use non-pharmacological intervention. It helps with that relationship and interaction. So as a next step, it would be, I think, beneficial to explore this in detail to really understand it.
Yeah, kind of to drill down and figure out which specific interventions have the most positive impact, and maybe even, the time frame for administering them, if there's any, more efficient way of doing it, right? So Aza, one of our PhD students, says excellent presentation. Dr. Diane Barish also says, thanks so much for your presentation. Excellent job. She's asking if you were to recommend one policy change or training intervention to improve staff-patient communication, what would you suggest?
Yeah, I think it's really, thank you for the question. It's a really interesting question. And especially when we do research and, present these findings, we always, on the back of our head, think about possible policy or research implications of this work. And, policy implications are, as we all know, it's not, they're not quite smooth and easy to implement, but still, I think one thing that could be considered is, like you mentioned earlier, Jan, is trying to have policies or provisions around availability of the resources to support the use of non-pharmacological interventions in these settings. So I think I would really love to see that. And it's, I guess, something implementable at some level at the settings. So that's one thing that I would love to see. And in terms of training intervention, again, perhaps doing educational interventions on some of these non-pharmacological interventions. Just even covering topics like how to make time for these interventions and when would be a good time and how to conduct them would be beneficial for staff.
Yeah, I was curious, the two key findings you identified in this study, the impact of pain negatively associated with quality of interactions and the positive impact of non-pharm approaches. Did you have an opportunity to kind of circle back to the staff and share those insights with them? And how does that part work? When you're done with your study, do you go back and share your findings with the staff so they can learn, what you found and what they might be able to do to improve?
That's a really great point, Janice. I think it will be beneficial, both beneficial and important to share these findings with the staff. I believe the study is now at completion phase, so I will definitely convey that message to our.
Yeah, I would imagine there's a certain time that you need to wait to do that, so it doesn't impact your study results, but just curious, from a nursing management perspective, I'd want my staff to know what you found, to help them improve. Jenny, do you want to unmute and ask your question aloud?
Sure. I'm going to include a quick comment as well, kind of going off. It's interesting kind of talking about the next steps and things like that. And as you both know, we've been doing OMA within kind of long-term care facilities. And Megan McGraw, our colleague, had asked the nursing students that are paired one-on-one with the older adults a couple weeks ago, just kind of a general question of, do you see yourself in your nursing career implementing, like being able to do OMA, like during a shift, like being able to take a little bit of time to kind of connect with your residents? And the students said, no, I think we'd be too busy. And so I think you have a great point. I think time is really a huge factor, and thinking about how to systematically change kind of the bigger picture so that we can implement these findings. But my question was, if you could just, for those who aren't familiar with it, just describe, I guess, what the FAM-FFC is and how you decided that this was the data set that you would use for the study.
So, as I mentioned earlier, FAM-FFC is one of the clinical trial funded. It's R1 study being funded by National Institute of Health, and the principal investigator is Dr. Murray Bolts from Penn State College of Nursing. This study is really focused on optimizing function through 4 steps. And those steps include stakeholder engagement and developing function-focused individualized goals for the patients, assessing some of the aspects of the environment within the hospital setting. And the other step is staff education on this topic, especially around how to engage patients in their own care, or just as a collaborative effort. And the final step is mentoring and motivation of staff to continue to practice what they have learned during education. So it's really these 4 steps coming together with an end goal of optimizing function among hospitalized patients with dementia. And the second part, answering the second part of your question, I had been looking at, this has been my core work. I'm really passionate about this topic, and I have been doing some of this work in long-term care settings. And I really wanted to see like this across settings perspective of what does this look like, even the interaction in general, and what factors can influence, especially given the slight variation in hospital versus long-term care settings. If we think about nursing home and assisted living, maybe there are some similarities, although there are still some differences. But when you come to acute care, it's totally different, right? Like no long-standing relationship, such a fast-paced environment. So I was really interested in that. So ended up looking at this outcome based on the data we had.
That's fascinating. The differences that you identified there in relation to more of a long-term care setting versus an acute care setting. I think further exploration of that would be intriguing too. Sarah Songer is asking, is there research going forward related to application for non-dementia patients, so patients that do not have a diagnosis of dementia?
I think it would be great to go that route or explore that avenue with non-dementia patients. As of now, I don't think I have a yes or no answer, but I do believe it's an important avenue. And we can definitely adapt this work for non-dementia patients as well.
Yeah, Kim Strife made a comment that it's also important to establish day versus night routines. So
Mhm.
helping a person with dementia with their circadian rhythm, because that can certainly be disrupted with dementia. Lights out at night in the hospital setting can be a little tough. Any comments related to that?
Yeah, you know, as I was doing this work, I was thinking, you know, a lot of this data that we collect is during the day. So we really don't have much information about, like, you know, evening, night shifts. So perhaps that's one area, well, additional area to explore in the future. But definitely, I agree. It's important to establish that circadian rhythm and you know, be considerate and understanding of that normal sleep routine. But then it's also important to understand what happens during from like evening to night hours and explore ways to examine that.
Yeah, that was an excellent point, you know, that there's certainly could be a lot of differences or maybe some similarities to evening and nights as well. But great to explore that moving forward as well. So Aza is asking, do you recommend specific communication strategies that it can improve nurse to patient interactions?
We are getting a lot of important points and questions today.
We are. We
Really
are.
another important point and question. I think when it comes to interacting with persons with dementia, residents with dementia, patients with dementia, whatever we call based on the setting, the core is to really knowing the person, understanding their communicative strengths and limitations, and then utilizing the appropriate positive strategies, which are all that we learn every day. But then, you know, amidst trying to getting our work done, although we are aware, we tend to forget to use those, listening with respect, with patience, and really trying to understand that communicative intentions, that being at the eye level, trying to be a facilitator. Yeah, I think these are some of the strategies, but like I said, it really boils down to understanding the person, their strengths and limitations, and trying to be a facilitator and actively engage them.
Yeah, when you were comparing long-term care to acute care and talking about the fact that, you know, it's more of a long-term relationship in long-term care, you know, staff in an acute care, a hospital setting, probably are a bit more challenged because they don't know the person as well. You mentioned this, you know, the concept of knowing the person and how important that is, you know, who they are, how they effectively communicate, you know, what their preferences are, what their customary routines are, you know, what things might cause them distress, or, you know, what needs they might have in a given moment. So thank you for sharing that. So Sharif says, excellent presentation, Dr. Paudel. Khalid says, thank you for your earlier answer. Great focus. Have you seen any literature review on animal-assisted therapies? If so, you know, could you share a few examples of that?
I actually, as I was working on my other work in assisted living setting, I came across this wonderful study by Dr. Erica Friedman at University of Maryland, where she looked at the influence of pet therapy, dogs particularly, at these settings and how they can help improve the mood. And help with.
So a real dog, right? A live dog. Yeah. I asked that because there are the, robotic animals that are sometimes used with
Those
dementia
two,
care too,
yeah.
right? The cats, the
Cats,
dogs,
yeah, I think
even
those
a
are most
seal, I think. Yeah.
exactly, yeah.
Yeah.
Cats, dogs, and robotherapies are emerging work.
Yeah. And I think, I'd be curious to know if, that was one of the resources that the nurses considered, because a
Mhm.
lot of hospitals have a therapy dog
Mhm.
available now. I don't know how you access that, how that exactly works. If somebody knows, please feel free to unmute and share that. And maybe but I'm not familiar with how a nurse in the hospital setting on a medical unit, for example,
Mhm.
can get a hold of someone to bring the therapy dog, or if that has to be scheduled. Not sure about that. So Dr. Yingling Zhao says, great presentation. And she's asking if you could expand a little bit on how your results were similar to or different from the findings in long-term care. You did talk about that. Is there anything else you'd like to share in relation to that?
So really, it seemed like the findings are similar across the settings. Perhaps sometimes, these findings can be sample specific, but I think in the assisted living nursing home, we did see behavioral symptom of distress, such as agitation being associated with interaction. But one thing just crossed my mind, pain. I don't think we really saw the association between pain and interactions in long-term care settings. If there is some work I might have missed out on, but based on my review so far and my prior work, we didn't see that association. But then we see that the association between pain and interactions in hospital settings, which made sense, right? Because it's one of the common clinical symptoms, which is prioritized for management in acute settings.
Mhm.
So that was the major difference we saw. Otherwise, in terms of the quality of interactions in itself, they were similar. There were like very minor differences, but for the most part, it was similar.
So I see Donna Fick's image up on the screen. Jenny, did she want to unmute and share her comments? Thank you.
Oh, I don't see myself on the screen, but I was just going to say that I put a link for pet therapy, and that's actually one of my papers from the 1990s where we did pet therapy, and it does actually walk you through how you do it. And a lot of that is dependent on state laws and nursing home visitation, but it's very doable. We did it as students, and it was a lot of fun. So just and it doesn't look like it's full access, but it is. If you click PDF, you can get full access. And great work on you. It's just so important, and especially right now as we're grappling with everything that we're grappling with in terms of the workforce. So thank you, and you have a long career.
We have a question that was put in the Q&A. What measures or strategies could be suggested to integrate non-pharmacological interventions into routine dementia care protocols effectively?
I would highlight two key things. One would be related to time. So that's something that really needs to be explored. And I think utilizing activities staff or activities, unit, especially that's what we see in long-term care settings, but trying to find something similar in acute care settings. Maybe it's, we have social workers, so can we, have part-time staff and mobilize the expertise and skills of social worker? That I think those are some of the ways that would help to implement non-pharmacological interventions.
Really, yeah, using kind of that team approach. So not that it's not just nursing that needs to implement these non-pharm approaches, but maybe, get other personnel, to be a part of it. We have time probably for one additional question. Diane was saying, going off what Janice said, I think she was talking about in relation to non-farm approaches. When a long-term care resident comes into the hospital, for example, there's kind of the red bag thing, or some places use a green bag, but essentially a long-term care resident, when they're hospitalized, brings a few familiar items with them. That's what I think she's referring to there. You know, that would help the transport of someone from hospital staff to get to know their patients, you know, so there's often kind of a all about me form in there to tell them some key information about the person. Can you comment a little bit about those strategies?
Yeah, I think that in fact would be the first step towards, you know, integrating some of the more personalized non-pharmacological interventions, like when you know what the person likes or dislikes. I have volunteered in OMA, and you know, we do some of these things there. And you know, if there's a list that says, you know, this person really likes music from, you know, this singer, then it's really helpful to curate that playlist for that person. So definitely it would be perhaps the starting point.
Yeah, so really working on those care transitions when someone's, you know, transferred from a long-term care facility to the hospital, sharing key resources and information. So thank you. Well, thank you so much, Anju, for a fabulous presentation and for answering all these wonderful questions that people had. Thank you to the audience for your participation today. I thought it was a great, you know, dialogue. A couple of quick reminders as we're concluding. The November 30th seminar on aging inequalities by Dr. Kelly White will be rescheduled as part of our spring 2024 series. So you'll see an announcement about that being canceled soon. Jenny has put the link to the survey, the evaluation tool for the seminar, in the chat. If you have time to complete it now, please do. If you don't have time, you know, we do appreciate everyone completing the evaluation. You will receive an email with the link within 24 hours. But it does need to be completed within a week of the seminar if RNs or others want to, or if RNs want contact hour, if they're seeking contact hours. And evaluations, again, we do appreciate them from everyone attending the seminar. It helps provide feedback, and certificates will be mailed to RNs within a month. So thank you again, Dr. Paudel, for an outstanding seminar, and to everyone that participated today. I hope everyone has a great rest of their day.